Hi, this is Dr. Chris Doherty here. We're going to go over a concealed meniscus tear. We're looking at the lateral meniscus of this patient. There is no tear on the lateral side. This patient's had a previous arthroscopy where the surgeon went in and didn't see any pathology, even though the MRI had said that there was a tear and the patient had had continued pain for an extended period of time. They were unable to identify the tear itself. The patient continued to have pain for several months after surgery and had presented for secondary evaluation. The exam showed significant joint line tenderness medially, no plical pain, but pain right at the meniscus. As we probe the lateral meniscus, you can see a nice contour. It doesn't buckle and it's smooth. Here we're going to probe our medial meniscus, and immediately you can see a buckle within the meniscus itself. You can see it runs from that posterior horn almost to the middle 1/3. This is the site of our tear, and this correlates exactly with what we see on MRI. On the superior lamina, we can actually see some scuffing along the meniscus. We'll have to trephinate our medial collateral ligament to give us better access for visualization, but we can see that this is the site of the tear. I can actually flip my probe into a few small segments that extend all the way to the articular surface, but it's not a contiguous articular surface tear. It's primarily concealed within the meniscus itself. It will eventually reach the articular surface. Hence, we'll go ahead and repair it while we're here. So I'll go ahead and trephinate this meniscus itself as well as the medial collateral ligament. There was an article published in 2015, I believe, by Arnold that showed better healing with trephination as opposed to rasping, so I trephinate all of my repairs. So once we've got the meniscus trephinated, we'll make sure that we've trephinated the medial collateral ligament enough to allow access, but not enough to rupture the ligament itself. We're mostly inducing a grade 1 type sprain in that MCL to give us access. So here we bring in our Novostitch Plus, and you can see as I push now, it's easier to see that tear because we've gapped the knee more, gapped the collateral ligament to allow us to get access. This meniscus is small enough that I can reach all the way to the back on a single throw. Otherwise, I would have to do the under-over technique. Here I'm going to push up against the meniscus so it doesn't spit, so I can get that second suture past. And then I'll go ahead and start tying my vertical mattress suture. So I put one at the posterior horn, and it's easier to see that surface scuff here on that femoral side. I'm going to pass my suture. I've already passed the far side, so I'm passing the near. So we'll go ahead and tie these vertical mattress sutures. Now as we move to our lateral portal, visualizing from medially so that we can pass our sutures more anteriorly, you can see to the right of the screen the tibial extent of the tear. Whereas as we get towards the middle 1/3, it hasn't gotten all the way through the meniscus itself. So we'll go ahead and pass, and here's a tip. As I extend this lower jaw and get under the meniscus, you'll see me lift up. That keeps the needle from binding on the tibial plateau. If you don't have enough gap because the medial collateral ligament isn't gapping enough, then you'll have significant resistance to sliding that needle, and you might actually miss that upper jaw. So the tip is trephinate the medial collateral ligament and lift up so that your needle can glide freely into that upper jaw and pass that suture easily. So once we pass on both sides of the tear, we're just going to go ahead and tie. And now we've repaired a concealed meniscus tear. Had we left this alone with this continued pain and the fact that we can see it goes to the tibia there, it would have just continued tearing along this margin.